Right, questions by anything? Assignment 2, all done? All right. Due today at 5 o'clock. Okay. Last time we were talking about sampling. And so this time we're going to go through a few articles about and sort of to look at what we want to do is look at dependent variables, independent variables, sampling problems that can occur, etc. So let's start with this one, motives for seeking a second opinion. First off, structured or unstructured, abstract? Structured. So what's the article about? And where would I go to figure out what the article is about? Ooh, I know. Go to the last sentence of the opening section. Good answer. I decided to just answer my own questions from here on out. So let's see. This article addresses 3 questions concerning a specialist. We'll highlight it so it becomes nice and highlighted. Do patients seek a second orthopedic surgical? Why do patients seek a second orthopedic outpatient opinion? Who initiates such a second opinion, and which patient's characteristics influence the process? And do characteristic settings and views of first consultation impact the decision for a second opinion? Okay, so who were the participants? Groningen of Groningen University Hospital. So all new patients visiting the orthopedic surgeon were asked to participate in the study based on informed consent. A visit for a second opinion was considered to have occurred if the patient had visited at least one other consultant for the same complaint within the previous 2 years. Right? So what they're doing is that they're going into a hospital and they're going up to patients who are visiting the new patients in the Groningen University Hospital. And so then they're looking to see how many of those people were there for a second, who had seen someone within the last 2 years. And so they're going to consider that a second opinion. Right? Then it says patients who referred for specific diagnostic or therapeutic interventions required referrals to a tertiary hospital was excluded for the study. Why did they say that? What does that mean? So who they excluded people who were there because they had a referral, right? So what it means is that if somebody, like if I go see my GP and for my orthopedic, and the GP says, oh, you really need to go see a specialist, and the specialist is at Groningen Hospital, and so then they give me a referral to Groningen Hospital. It means that I'm not there seeking a second opinion. I'm there just because my primary care doctor referred me over. Okay. Patients were asked to complete a self-administered questionnaire before seeing the second opinion consultant. Information was used to confirm. Blah, 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 blah. So this is information used in the current analysis from social demographic second opinion consultation. 14 items represent possible screening motives. And it says based on extensive clinical experience in treating second opinion patients of the 2 authors. So what does that mean? So they got 14. So it says 14 items representing possible motives for seeking a second opinion based on the extensive clinical experience of 2 of the authors. So what's that mean? Yeah. Yeah. So, I mean, how else could they have come up with those 14 items? I mean, how, because what they're doing is they're coming up with this whole list of, of possible reasons, right? These 14 items is what they came up with. So, patient was concerned about diagnosis, et cetera, all the way down. How else could they have gotten those type of, this type of list? I mean, because clinical expertise is one way of doing it. How else could they have done it? Gone through the literature? Oh, yeah. Gone through the literature, that's another way. Ask people, so did a qualitative study, or the qualitative study would have gone through and kind of talked to people who are looking for a second opinion. And so you look for different types of reasons. So there are different ways that they did it. Is that a limitation of the study? Is this a limitation of the study? Is the fact that their primary list came from just two experts thinking of this list? Yeah. Yeah. I mean, who knows what these people, I mean, because these are not patient advocates who are used to working with them, with people with second opinions. They are just two of the authors, right? Who basically sat down and came up with what the list is. Okay. 8 items characterize the relationship of the first opinion consultant, and 3 items skepticism towards physicians. The final data related to the question of asking whose decision had it been, the GP or the consultants. Why might the GP, why might they, the GP or the consultant say to someone, why don't you get a second opinion? I mean, why might people do it? Why might I go, why might an individual go seek a second opinion? Yeah. Yeah, dissatisfaction. Well, the list is here, right? Dissatisfaction, results for disapproving, etc. Right? So there can be lots of reasons why it is that an individual might seek a second opinion. Why is it that a physician might say it's not, why don't you seek a second opinion? So it could be is that they're thinking, I don't understand, I don't know the patient well enough, so therefore go seek a second opinion. Mm-hmm. But this is not a referral, right? So it's not the same thing as saying, I'm referring you over. It's just like saying, why don't you go get a second opinion? So that's usually, yeah.
Dissatisfied, they might come to realize, okay, what I'm gonna say might they have not listened to the
Yeah. The patient could be a pain in the ass, basically, right? The patient could be a pain. And so the GP is like, look, why don't you go seek a second opinion, right? Which is, that happens when patients are not satisfied and keep pushing the GP, then it's like, fine, go seek a second opinion. So it can go either way, right? It can be it could be dissatisfaction with the GP or on the part of the patient, or it can be dissatisfaction with dissatisfaction with the GP on the part of the patient, or dissatisfaction with the patient on the part of the GP. Okay. One would expect that motives for patient interactions would be different from physician initiated ones. Unfortunately, practice not always clear, et cetera. Given that the most likely role of GPs in second opinions were attributed to the GP and patient initiated second opinions were taken together. So what they're basically saying is that we can't tell, right? We can't tell necessarily whether the GP initiated one was because the patient was a pain in the butt or not. So, okay, let's see. So, what was the sample size? First off, so explain to me how they recruited people. Yeah. Uh-huh. Yeah. How many patients did they get? How many patients did they give the questionnaire to? Yeah. And what was the response rate? Yeah, so 78% or 72%, right? So 72% means they gave it out to 2,000 79 people, and of that, they got a response rate of 72%. Is that good? That's pretty good. I mean, on the other hand, they're in a clinic, right? They're in a clinic and that the person's sitting in the waiting room. And so they come up and say, hey, would you mind filling out this questionnaire for this study? So some people might say, no, I want to do it. But I mean, they're getting people when they're just sitting there in the waiting room. So probably not surprising they get a 72% response rate. Then how many did they actually end up with? What was their final end? Yeah, 625, right? So down here, so it says 625 define themselves as seeking a second opinion. 26% had sought more than one opinion. Okay. So what were the dependent variables and the independent variables? Like, we'll take a look at this table. What were the dependent variables and the independent variables? Start with the independent. What were the independent variables? Yeah. Yeah. Mm-hmm. Yeah, just all the way down, right? So all these things on this side are the independent variables. Right? What's the dependent variables? Yeah. Yeah. So whether they sought out a second opinion. So what they're doing then is that they have, so their total N for the study is whatever is up here, right? Their total N is let's see, let's find the total N. What's the N? Anyways, their total N is all these people fill out the questionnaire, right? And then what they did is they split it out by people who said that they were looking for that they were the patient seeking it, or it was the doctor seeking, telling them they're seeking it. So either 321 or 36. Okay. All right. Let's do the other one. Okay, this one. Go to the bottom. Does this explain does this last paragraph tell them what they did, what they were doing? So what were they doing in the study? Yeah. So now in common, I mean, in regular language, what did they do? So how did they recruit people? Let's go down here under sample, right? So explain to me how they recruited people. Yeah. So they went to, did they give them out to did the researchers give out the questionnaire for the patient? How did they do it? They brought them to general practices, right? And they said to the GPs, would you give out this questionnaire? And so then the GPs gave out the questionnaire. And the GPs then collected the questionnaire and they got the questionnaire from the people, they got them back from the GPs, and then that's how they sampled people. Right? Problems with that sampling method? Good question. Yeah, good point. So who is the population they care about? I mean, we'll put it this way, who's the population that they're sampling from? Say it louder. Or, well, these are asymptomatic. So these are people who are not in there for any type of symptoms of colorectal cancer. So it's asymptomatic. So the population is right. People go to the general practitioner. That's the population. In fact, even more specific. Well, yes, that's their population. These people go to the general practitioner. In the other study, what was the population here? Right, in this one about the second opinion. What's the population that they're interested in? Say it loud. People who would seek, well, their general population is everyone who has some type of consultation about orthopedics, right? That's your general population. And what they're looking at is just trying to see how many people of that population seek a second opinion. So if you were going to go through and do this study, let's say, then, and you wanted to find out, how many people really are going to seek a second population, it's a second consultation, then what's your population that would you care about? Well, everyone, right? And where are they sampling from? The Groningen Hospital. So it means that they're in population, is everyone, right? Everyone who has some type of orthopedic issue. And what they're doing is they're looking at drawing. And so then, if you have a subsample of people who see the second opinion. And so they're looking at drawing again to sort of see, this is the sample, and this is where they're getting the data from. And this is the people who see the second opinion. And so, the question is Groningen representative of this whole, of everyone who's based in the orthopedic? Well, I mean, where people seek second opinions. Like, who would go to Groningen to seek a second opinion rather than? I think it's okay, right? I can't think of any, because to say why this is different, you have to think, well, so there are people here, these are all the first, people here going for the first consultation. Then you have a subsection of people go there for the second consultation. Well, where are most people going to go for a second consultation? Well, they're probably going to go to someplace that's more of a specialist type place, like going to a hospital. Like they're probably not going to seek a second consultation in the GP's office. They might, but probably not. So it probably means that most people are seeking a second opinion by going to places that are tertiary type centers like that. So then the question is, are the people who get their first consultation here different than the people who get their first consultation out there? Because it could be that only people who are, wealthier and more well-connected can kind of get into going to a hospital. On the other hand, it could be, and so therefore, maybe there's a whole bunch of people out here who would like to get a second consultation, but that they differ significantly from that group. It could be like that. There's no reason I can think of for that, to do that. So in the other case, now our population is people who visit the GP. And what they're doing is they're sampling, 22 offices. And then they're getting the GP to give out the surveys there. And so then the GPs are collecting the surveys. Right? So if you look at what the response rate of these GP offices, was the response rate pretty much all the same for these GP offices? As that, did all GPs basically send in the same number of surveys? No. What was it? What did they say about who sent in most of the surveys? Okay, so you had some practices that had like 80%, and then you had other practices that had almost none. So the question is, are these practices that have high response rates different from the practices that have low? Are the high response rate practices different than the low response rate practices? What do you think? Why would a practice have a high response rate versus a low response rate? What's the response rate? So probably not more patients. I mean, it could be. It could be is that, like if you're looking at colorectal cancer screening and you have a bunch of children, is that you're not going to give them a questionnaire. So if you're just a pediatrician, then you're not going to give out a lot of questionnaires that say, would you rather have an FOBT or a flexible sigmoidoscopy? Was that the two that they're looking at? I think it is. You know what FOBTs and flexible sigmoidoscopies are? In this country, they mostly use that colorectal cancer screening, which, they put you under and go up and knock off all the polyps and things. Flexible sigmoidoscopy, I don't think they knock you out, but they basically just put a camera up you. And that then to sort of, look to see if they see any type of things, but it's not like a colonoscopy. It doesn't do get the little polyps off like they do with colonoscopy. And then an FOBT is basically just poop on a card and send it in. And so most countries use, what do you think most countries use? Do you think most countries use colorectal cancer screening like that, like we do here? Or do they use FOBTs or flexible sigmoidoscopies? Which one do you think? Most countries use the FOBTs, right? The only country that uses colonoscopies as the main thing is the US. So why does the US use colonoscopies more than these other countries as the main screening tool? Because doctors get paid $25 for an FOBT and they get paid about $1,500 for a colonoscopy. So anyways, and then there's more sacred reasons as well. Like, colonoscopies, if you can get it once, you only have to have it done every 5 or 10 years and they can find polyps and there's all these different things. But colonoscopies also have lots of problems that go along with it. So that, like oftentimes they can tear the insides, which is bad. So there are bad things that can happen with colonoscopies, which is why a lot of countries just use FOBTs. Flexible sigmoidoscopies was a thing that was kind of, at the time, back in the early 2000s, was a big debate about whether to use that as well. But as you can imagine, a lot of people don't like it. So therefore, that's why what these studies were about was basically to go through and to sort of see, what would people prefer? Would people prefer one or the other? Well, first off, would they prefer either one? And then would they, if they prefer one, which one would they prefer? So that was the study. Okay. So now they sent out these things to these GP offices. GPs then give them out and they return back like the surveys. And what they're saying is that there were a couple of GPs that did a lot of them and other GPs that did almost none of them in terms of getting the surveys. So what were the results? So go back here. What were that? Let's go down here. There's your table one, right? Your demographics. So this is now prepare to take the screening test, right? So this is like the that whether, well, what's the dependent variables and independent variables? What's the dependent variable here? Yeah, what's the dependent variable? Well, it's the willingness, right, to take a test. So either yes or no. What percentage of people were willing to take the test? I'll let you find this out. You can look through and figure out how many people were willing to take the test. And then, so this is like who's going to take the test or not. So, again, here's odds ratios, all right? And so what they're doing is, reporting all the independent variables going on this side, right down this on this. And then this is if they had a preference, then first off, this is who had a preference. So this is dependent variable on this one is would they be willing to take a test? This one is did they express a preference, and if they express the preference, then which one did they prefer? And the FOBT is the one. So like if you look at this is sex is equal to females, right? Sex is and females is equal to 1. So did they prefer an FOBT or a flexible sigmoidoscopy? Did they prefer an FOBT or flexible sigmoidoscopy? Let's see. So female equals 1, right? That means that so the way if you when they do these types of present these type of results, what they're showing is that when they say female equals 1, that means that female equals 1 and male is equal to 0. So that's why it's always a 0 1 variable is what they're doing. So for these types of these are called dummy variables. A dummy variable is when they just create a variable that's a 0 1 variable. And so then they're going to tell you which is the one, which is the, what is the variable. And so then if you look at the coefficient on that's highlighted there, if the coefficient is positive, it means that, what do you think? Females are more than males or males are more than females? Females are more than males. Females more than males. And if the coefficient is negative, that means the other opposite, that males. Okay. And so that's a dummy. So let's see any other dummy variables in there to poke out. Worried about cancer. Okay. So notice that worried about cancer, they have it as a dummy variable. And obviously it was a 4-point scale or a 5-point scale, of which there's 2 of them. They've given the value of 1. So 1 if you're worried about cancer, and 0 if you're not worried about cancer. Are people who are worried about cancer, are they more likely or less likely to choose an FOBT? Say it louder. Less likely, right? Because it's this number here, and that number is negative. So it means they're less likely to choose an FOBT. So they're less likely. Does that make sense? With people who are less likely, are more worried about cancer, more likely to choose a flexible sigmoidoscopy? Yes, because it's more accurate. right? Plus flexible sigmoidoscopy is more accurate. So you can imagine that if you're worried about cancer, then you probably would actually prefer a colonoscopy. On the other hand, if you're not worried about cancer, then you might not want to have, something stuck up to you. So instead, you're going to choose a FOBT. So that makes sense. So those are dummy variables. Then you have the variable age. Age is a continuous variable, right? Because they have like, it goes like 18 to 80 or whatever the ages of the people are. And so it's a continuous variable. And so in this case, are older people more likely or less likely to choose a flexible sigmoidoscopy? Are they more likely or less likely? Less, right? The higher your age, the lower your likelihood of choosing the FOB and FOBT, right? The lower your choice because it's negative. So they are less likely as you get older. That makes sense? Does that make intuitive sense? Well, yeah, probably older people are going to be more worried about, cancer, and they're also going to be more willing to sort of do things that are invasive to kind of detect cancer. Any questions about these things? So like in terms of preference for a test, are women more likely or less likely than men to just express a preference? They're more likely, right? Are marital status, let's see, where it is. Marital status, well, let's pick another one. How about, oh, so this is a dummy variable now. See, it says low income dummy. So dummy variables, so what they did is they basically said if you're $10,000 and below, then they gave you a value of 1. And if you have an income of $10,000 or 10,000 pounds or more, they gave you a value of 0. So are people who are low income, are they more likely to want to test or not want to test? Are people with low income more likely to want to test or not want to test? Not want to test, right? Because, I mean, this one's kind of flipped because even though it says income, you think about income as being, income usually is a continuous variable that goes from 0 to 100,000. Is usually your income variable. They flipped it because they're saying low income equals 1. That's the people who are less than 10,000 pounds, right? And low income is equal to 0 is basically people who have income greater than 10,000 pounds. So it's almost like they flipped it around. So rather than showing that, rather than sort of just doing high income versus low income as a 1-0 high income, they now do 1 is a low income. Does it make a difference in terms of the results? Does it screw up your results? No, it just makes it more difficult to figure out, right? It's like, why didn't they just have high income 1 and low income 0? Who knows? But that's what they're doing there. So they're creating a dummy variable, a 1-0 variable. Okay. So overall, it suggests that this is logistic regression results, risks, worries of medical risk of getting colon cancer, and so now they're predicting that risk of colon cancer. So what they're doing here is that they know that risk of they know that risk of your worry basically is going to be related to your age and other types of factors. As you can think of the way the model works, I mean the way that life works, right? Is you would have age is related to worry about colon cancer, and that's related to willingness to get a test, right? So you think that age is going to be positively related to worry about colon cancer, which is going to be positively related to worry about getting a test. But then you can also think, well, you also have income. Age is going to be positively related to income, which is positively related to getting a test. And then age can also just, it could just be as that, maybe older people are smarter. And so they just know that they want tests. So that age can have an independent effect of getting them too. So when you start to draw up these models, these the pathways there between your independent variables and your dependent variables, is they can get kind of very complicated. These things up here are called indirect effects of age. These things here are called indirect. So you have direct and indirect effects that go through this way. So statistically, they have ways of kind of trying to sort this out. They do a lot of what's called path analysis, which what they're trying to do is they're trying to figure out, does age have a direct effect? Does age have an indirect effect? And such. So that's kind of what they're doing. I mean, that's what statistically they do. That's why they're showing this, right? What they're trying to do is they're trying to say, okay, so what's related? Because knowing that they have this relationship here, what's related to basically worry that's independent of all these things? So sometimes you'll see that. Sometimes you'll see, when you look at paper, you'll see that this is the dependent variable, right? And these are the independent variables here. But then you'll also sometimes see these things as the dependent variables and these as the independent variables. Because what they're doing is they're basically testing them out. It goes along. Okay. Yeah.
We asked a question about independent variable. Would it then depend on, how are they connected in that pathway?
Yeah. So what I would suggest you do is you look at the table, because the table, the tables are all pretty much set the same, where they, like in this case, table 2 test preferences. So that test preferences is your dependent or independent. Which one? Dependent, right? That's your dependent variable. So it will usually tell you at the top of the table what your dependent variable is. And then your independent variables are all kind of like this going down. The paper we looked at the other day where it showed it was the stress across time, and they had four different time points. That one was a little confusing because you still had your independent variable of stress, and each table was a different, dependent variable. Each table was a different dependent variable for stress. But then, and you had your independent variable going down the side, but also the time period was an independent variable as well. Even though they listed it kind of on top, it was really an independent variable because, time is independent of stress. So that's why it's a general rule that they'll put the dependent variable up here and the independent variables this way, but you just sort of have to, think about it. Like in this case, you'd say, okay, these are definitely on this side are all independent variables, but these things up here are all different dependent variables. So they have essentially 3 dependent variables. The first one is like, who wants to take a test? The second one is that, do you have a preference of the test? And the third is that if you have a preference, what is your preference? So they have 3 different dependent variables. And this happens a lot when you, when you start to look at, like we do this for needs analysis. Like if we want to look at needs and unmet needs, is that you first go through and you do it and you sort of say, who has any needs, any health needs? Okay. And so you have a yes and a no. And then you say, okay, so if you have health needs, were they met or unmet? And so then you have, you're just only taking this group here, that they have health needs, and you have yes is equal to met, or no is equal to unmet. And so then you can look to see, well, what predicts whether someone has met or unmet health needs, but you want to take these people out of your equation because they don't have any needs, right? they don't have any health needs, so. And you want to, so if you're looking to see, well, who has met versus unmet needs, is that then you have to take these people out. So that's kind of what they're doing. They're first looking to see who has any preferences. I mean, who would want to take a test? Then they take those people out and they say, okay, if you said you want to take a test, do you have a preference? So then they take those people out. And then, yeah. Okay, so back to the sampling. So what's the problems with the sampling in this case? So given that we have this type of sampling method, we know what our population is, right? Population is everyone who goes to a GP.
Mhm.
So what's the problem? Why might you have a bias sample in this case? First off, do you have a selection bias? Yeah. Why? What? Because the selection bias is that you've got some people who have big responses and some people have small responses. Right? Why is that a selection bias? And what do you think is going on? I mean, some of it was like 80% respond, 80% kind of said that they, that they got responses from it. So if you think about how this is working, GP comes into the, to talk to the patient. GP says, would you be, willing to take this survey? And then they give the person the survey and the person, either says yes or no, and they fill it out or not. So some GPs are just not gonna give them the survey. So why wouldn't a GP offer them the survey? Why wouldn't, what's the difference between GPs who will offer the survey and GPs who will not offer the survey? Any difference between them? Probably enthusiasm around colorectal cancer screening, right? I mean, if you're a GP, if I came in and said, I really want you, the GP, to talk to your patients about brain infestation by aliens, is that the GP might say, okay, and then just never do it, right? Because the GP might think this is a stupid topic. I'm not going to waste my patient's time. On the other hand, if I came in and said, GP, I want you to, here's this product that you can sell your patients, that you can get a whole bunch more money if you sell your patients on this product, then the GP might be, some GPs might be more willing to say, I'm enthusiastic about talking to them about about this. So somewhere in between those two things is basically what's happening here, is that GPs who are enthusiastic about FOBTs, about colorectal cancer screening, are likely to say, oh, you should get colorectal cancer screening. And so, and if that occurs, then, imagine you're in the GP's office and the GP says, colorectal cancer screening is really, really important, especially for someone of your age. Here's this survey to find out, to ask you, would you like to what you think about colorectal cancer screening? Most people are going to say, sure, I think it's great, right? And then, so they're more likely, because they're trying to please their GP in this case, because it's a bit of a, if your GP says colorectal cancer screening is really important, and you say to them, screw colorectal cancer screening, I think it's just all a money grab on the part of the healthcare industry. Yeah, you're probably not going to have good relationships with your GP if you do that. So there's a lot of pressure to basically to say yes, I'll do it. And what happens if they say that they get that they have a preference? Do they actually get the screening? Well, no, it doesn't say, but it's not like they're in the office saying, okay, if you say yes to the flexible sigmoidoscopy, let's go. We're ready to go right now. So it's not like that they're actually going to do it. So people can say, like my dentist always says, you should come back in 6 months to get, some type of deep cleaning on your teeth. That's going to be really painful. I say, oh yeah, I'll make sure and make an appointment about that right now. I don't want to argue with my dentist, but I'm not going to go back in 6 months and have a painful procedure. So you often tell things to healthcare professionals that, what they want to hear. So in this case, you've got some who obviously are talking a lot and getting high response rates from them. And you get other ones who are not talking to them at all. So what kind of bias would you expect here? What would be, I mean, what would the bias be? Just, and don't worry about the term, but just what are you afraid of? Yeah, so they're not going to give truthful responses to the GP. So, they're going to basically say what the GP wants to hear, what they think the GP wants to hear. So that's a problem with it. And how about the fact that is there a problem between this GP and these patients and these patients? Is there a difference in terms of, because of the,
Maybe the ones with like low response rate had a lot of people who didn't speak the language, so they don't fill out the questionnaire.
yeah, or maybe they're just, maybe these are GPs who they service more low income type of populations, and if they're busier, they have to get lots of patients through, they don't have time to sit there and wait while a patient fills out, or the patient doesn't have time to fill out on the GP. So there can be lots of sort of differences that exist. Yeah.
It can also be the GP might turn out depending on if the patients would be interested or at risk for it, so they're more likely than actually people kind of do it to get the for them.
Yep. So it could be is that if someone comes in, especially at these ones, if someone comes in and they don't smoke and they're younger and etc., then they may sort of think, well, this person's not at risk, so I'm not going to worry about it. Whereas the ones I'm going to give it out to are the people who I think are at risk. So therefore, you're just getting high risk type of use. So that's the type of, when you look at these papers, I think that's what I think you should, what I'm suggesting that you look at is take a step back and ask just sort of, there's not like there's not like some type of formula you can use from this. You have to just sort of take a step back and do a common sense, ask yourself, all right, so what are they doing? How are they going through and collecting the information? What's likely to happen? What would I say in these type of situations? That kind of, just have that kind of analysis that goes along with it. And every survey that you have, you can do this on, because it's really, really hard to get a survey where you don't have some type of potential bias that goes along. Like we use a lot of Qualtrics surveys now, where we basically pay Qualtrics somewhere around $5 to $10 per person to survey, and then people take these online surveys, and that then they get some money from Qualtrics. Is that a representative sample? No, not a representative sample, because it's basically people who are willing to take an online survey. So, it's just it used to be is that they would do telephone surveys. So telephone surveys were typically the way that they did lots of surveys back up until not that long ago, maybe 15 years ago. Telephone surveys were the way to do it, and they started to lose faith in telephone surveys, partly because people started to get cell phones, and so in cell phones you can't do it. You don't have the numbers for them. But the other thing is that who is it that's going to be willing to answer 30 minutes questions on a telephone survey? It's not most people. So that they were starting to get a very biased sample in terms of from telephone surveys. It's why polling for elections is so tough. Because polling, is that you first have to figure out how to reach people, and then you have to ask them, try and get them to accurately respond to you. So like if you look at 2016, when all the polls suggested that that Hillary Clinton was going to win by 5 points, some of them up to 10 points, and instead, she loses key battleground states. And so the question was, why were the polls so off in Ohio and Michigan and Wisconsin, all these different places? And so there's a couple of reasons why the polls were off. Right, one is that there was just a shift in the after Comey kind of comes out and says that we're still looking into Hillary's emails, is that shifted some people. But then the other one was that a lot of people, after Trump, after the Access Hollywood tape, where Trump, talked about groping women, is that a lot of people didn't want to say that they were going to vote for Trump. And so when pollsters would ask them, they'd say, no, I'm not decided yet. And so what happened when the election finally came is that all these undecideds broke towards Trump. So that, if you looked at like when they normally do a poll, they'll get like 40% say that they're for Hillary, and that Trump will get 35%, and then there'll be 25% undecided, right? Undecided, that sort of says, oh, we don't know what we're going to do. And so this is the group, that they try to go through and try to figure out. Well, first off, how do they know? Like, how do they, when they poll like this, how do they figure out who they're going to ask or who they're going to believe? They usually have a screening question, right? What's the main screening question that they use at political polls? Anyone been polled before? So what they ask you first? Or I ask you early on, yeah. Are you a registered voter? And then what else? Well, are you going to vote, and did you vote in the past? Because what they're trying to do is that's the best predictor of who's going to vote in the future. Is did you vote in the past? So the people who are uncertain are the people who are in this middle, who say, yes, I'm going to vote, but I've never voted in the past. These people tend to be, what kind of people tend to be? People who haven't voted much in the past, but say they're going to vote now. Young people, right? Young people tend to fit in that category there. And so, what campaigns try to do, like what the Democrats typically try to do, because most young people tend to vote Democratic, is what they try to do is they try to up the number of young people who are going to vote, right? Because oftentimes if they just look at only the people who are actually going to vote, I'm going to flip you guys off. If they look at the people who are actually going to vote and versus the people who say they're going to vote, is that the people actually going to vote tend to vote more Republican. The people who say they're going to vote, but haven't voted in the past, tend to vote more Democratic. And so Democrats try to get new people out, right? And Republicans don't try and get new people out because the new people tend to vote Democratic. So that's the first thing they ask, right? So part of this means that these people, so in polling, is that one of the things they have to figure out is that do you use only vote in the past as your group of people, or do you use intend to vote as the one? So like for midterm elections and for elections that aren't presidential years, this is much more powerful. Have you voted in the past? Because a lot of people say in midterm elections they're going to vote, but then they actually don't. Like if you look in Kansas, when Kansas had this referendum on trying to allow the state to ban abortion, and that they had, and it was predicted that it was going to be a very close vote, and in the end, it turned out not to be a close vote. Right? It was pretty solidly for not allowing abortion to be banned, and so there was like, ooh, why is that? Well, because what happened in Kansas is that the initial polls were all based upon on this idea that we're just going to only look at people who have voted in the past, especially if you've only voted in different elections. But what happened is that a lot of people, mostly women, who had not voted, don't normally vote in midterm elections. They came out because the issue was important to them. So therefore, it wasn't this that was the key thing, it was that. Usually though, midterm elections, it's this. And in general elections then, is that the question is, well, so which is it going to be? Are there enough issues that kind of that make it so that these people here, the intend to votes who've never voted in the past will come out or not? Which is why negative election tends to work, right? Negative campaign tends to work if you have more people who are going to, in this group, who are voting for you than this group, then negative campaigning works. Because what does negative campaigning do? A negative campaign, I mean, come out and like say my candidate is a scumbag, and and just get into that. What does that tend to do to voters? Makes them not want to vote, right? Makes them think they're all crooks, forget it, the whole system is rigged, I'm not going to vote, right? So if you do that, these people still vote, these people don't vote. So that's why if you're in a campaign and you're running for something and you're in the campaign, then ask yourself, do I mostly have people like this who are gonna vote for me? Or do I have to rely upon new people? And if it's people like that, then just start trashing their opponents. Just start taking negative ads out left and right.
They go really good qualified.
Maybe, or maybe you'd be, prominent in one of the parties pretty soon. It's hard to say. But that's the idea. But then you have these people, right? And you have these people over here who are always the ones who always say they're undecided. And so everyone, all the pollsters try to figure out, well, what are these people? How are they going to break? And so, they look at like a lot of the people who say they're undecided really are, they're either, they actually do have a strong preference, just that they just may not like either one. And so they're kind of in this camp of, if the negative campaigning is too high, is really high, they just won't vote. But they tend to be, to kind of know who they're going to vote for. When they look at intentions, undecided vote, there aren't that many people who are saying, I'm really for Hillary. And then 2 days before the election, no, it's going to be Trump. Right? There aren't. Instead, what it is that these undecided is that they that they can break both ways. But if you're someone, if the candidate has some type of something where people don't want to vote for them, like the Trump after the Access Hollywood tapes, then these people might still be for Trump, right? But they don't want to say they're for Trump. And so, what they'll do is they'll say, oh, I'm from Hillary, or I'm undecided, or whatever. So they'll put in that category. So pollsters know this. And so one of the things that pollsters try to do when they sample is to try and figure out, well, how do you go through and get these people's true responses? So this came up a lot in a few back in the maybe 2000, maybe a little bit before that. There was this candidate from Louisiana named David Duke, and David Duke had been a Grand Master of the KKK and ran as Republican, and won the Republican nomination for senator or governor. I think it was governor. Won the Republican nomination for governor, and pollsters were shocked because he was only polling in the low double digits, and that suddenly he wins. And so they were asking, well, why is it that he could have won? And the conclusion was because there's all these people in on Louisiana and the Republican Party who really wanted to vote for David Duke, but they knew that he was also he was a racist and used to head of the KKK, and so they didn't want to say that they voted for David Duke. And so what they came up with afterwards is a way of polling where you have a bag, right? And it can be a physical bag or it can be a virtual bag, but basically a bag where you have blue chips and you have red chips. And then what you say to someone is you say, well, look, I want you to pick a chip from that bag and don't show me the color. And then if it's red, I always want you to say that you're going to vote for David Duke. And if it's blue, then tell me your true opinion. Right? So let's say, if no one likes David Duke, and you do this pollster, how many people are going to look like that they support David Duke? So if no one's going to vote for David Duke at all, and they do it this way, so everyone's going to vote for whoever for Tamara. Everyone's going to vote for Tamara. So who is it that? So how much would David Duke get, and how much would Tamara get in terms of the poll? 50%, right? So because half the people are going to get red chips, and they're going to say David Duke, and the other 50% are going to say, oh, we're going to get the blue chips, and then say, oh, I want Tamara. So now let's say if David Duke is going to get 25% of the vote, well, we'll do it 50%. He's going to get 50% of the vote. Now, if you look at this, if you look at the polls, how many people would say that they're voting for David Duke? But he's going to get 50% of the vote. In reality, how many people, when you do your poll, would say they're voting for David Duke? It'd be about 75%. Right? Because you as a pollster knows that, oh, just take away 50% right away because it's red chips. So basically, at 25% versus 25%. And if you know, and if it's 25% for David Duke and 75%, then these numbers change. But in each case, what you're doing is you're taking away that 50%. So why does this overcome the problem of the David Duke problem? Why is this, from a voter standpoint, why can you trust this? I mean, from a pollster standpoint, why can you trust this poll more than just asking someone? Because you're giving the person a reason to say, I like David Duke, right? Because from the person's standpoint, it's like if they say, I like David Duke, then you're giving them an excuse to do it. Even if they really, really want camera, is that you're telling them. And on the other hand, if the person really likes David Duke, then they can say, I like David Duke. And the pollster will never know whether or not they actually got a blue chip. So what you do is you give an excuse to someone to be able to tell you what they really think. So that's a case where, where the act of telling who it is that you want is influencing your choice. So that's kind of the same thing as over here, right? It's the same thing here, which is that if the GP is asking the person, do you want colorectal cancer screening? And the person knows is that the GP really wants me to get colorectal cancer screening, then they're more likely to say. So if they really wanted to do this in the right way, they would find a way to let people be anonymous in terms of doing that. And then look to see are there differences between the different type of who goes to a GP. Okay. All right, let's see. Anything else about this? All right, so did that one. Let's see. There's also the this one here, right? The student one. So we talked about sampling in that one. Good sampling? Okay sampling? What was the problem in this one with sampling? Remember that what they did is they, come down here to the, is that, they had, the sample was, 1,275, and they ended up with a sample of 274. So what was the problem with this sampling, or the potential problem with this sampling? Yeah. Yeah, that's right. The selection or exclusion bias, where basically people were going to drop out along the way if they didn't, if they're under too much stress, that they may drop out. And also there's a problem with terms of who's likely to respond, because if you're under a lot of stress, then even if you're still there in school, you may not be willing to take a survey. So problems with that one. So any questions about this one, since this is, relevant to your homework? Yeah. Well, I mean, I think that the tables usually give you a clue from it, but it sometimes in the method section they'll actually say these are our dependent variables, these are independent variables, right? In this case, they go through and they start talking about all these different type of ways of talking about stress, right? And so, I don't know if they actually physically come out or purposely come out and say stress is our dependent variable, but that is what they're looking at. But then when you come down here to these tables, this table here, regression to predict stress linked to coursework. Right. The next table, regression to predict to procrastination. Next one, stress to life. So essentially, it's telling you in the title what the dependent variable is, and then these are your independent variables going down here. The only kind of caveat is that they also have these things up here. And these things up here are not dependent variables. This is another independent variable up there. Okay, any questions? Okay, so for next time. So next week I'm gone. We have Nimrat's in here on Tuesday to talk about how to do literature searches. And literature search is basically the third assignment, will be a literature search. Rudy's here on Thursday to talk about ethics. And then when we get back, we're going to transition into looking at basically designing a study. So, for the rest of the course, then what we're going to do is we're going to design and implement some type of study, some type of survey. So what I want you to do between, when we get back is we're going to essentially go through and think of our own type of, a topic that we are interested in. And caveats being is that it's got to be something that's a cross-sectional survey. I mean, it's got to be something that we can just do a survey. So we don't have to follow people over time, and we don't have to, and it's got to be on campus. So it's got to be something that we can talk to people on campus about. And also, related to something that we can, that people will know about, right? So students will know about, because we're going to go through and do partly, which is that do a brief qualitative study where you talk to each other or talk to other people about the topic, and then we're going to do a survey where we actually go through and survey, develop a survey and administer it. So it means it's got to be something we can give to people to fill out. Okay. And it should be something that deals with some type of, something related to public health. So it could be health behavior, like why people do one thing or another. Could be like use of services. So like one year, a couple years ago when we did this, we looked at the student health center and what people thought about the student health center. It could be sort of just prevalence of a belief or some type of attitude, something that we want to do. So think about it, because when we get back on the Tuesday that I'm back, then this is what we're gonna deal with, is decide upon what it is that we want to do for the rest of the semester. What's the topic that you want to look at? Good. All right. Then I'll see you in a week and a half, and Rudy will see you next Tuesday.